So today we're going to be talking about stigma and discrimination around mental health. My name is Jonathan Bachman. I'm a nursing student, and this is for my class, Nursing 384, uh, Behavioral Health Nursing. Uh, why is this issue important to me specifically? So I was in the military, specifically the Marine Corps from 2009 to 2016. During that time, I deployed twice, and after one of my deployments, I felt like I needed to seek out mental health and go talk to a professional about what I was dealing with. During that time, mental health had a huge stigma and was highly discriminated against active duty service members seeking out mental health help. So I went to my first appointment, and after my first appointment, I was like, okay, yeah, this is going to work out. Later on, I found out that my commanding officer was calling my physician for mental health, finding out what was going on with me, what medications I was on, whether I was deployable, whether I was able to continue to be fit in the military. During that time, it wasn't just me, it was all over the Marine Corps. It was heavily prevalent that if you went to mental health, you would be processed out of the military. So it was a huge issue, and I think that that stigma still lives on in some people today. It's gotten a lot better, but this has just been a giant issue within the military and something that I dealt with early on in my career. NAMI states that 1 in 5 U.S. adults experience mental illness each year, and that stigma fuels delay in seeking out help. So, what is stigma? Stigma is you have three different levels. Public stigma is stereotypes, prejudice, and discrimination. Structural stigma, which is laws, policies, practices, the unequally restrict care. And then self stigma is something that you put on yourself. It's you're talking down what your symptoms are, you're telling yourself that it's not something that you need to do, it's criticizing yourself, saying what's wrong with me, type things like that. So stigma can be in all aspects of your life. The impacts on healthcare, access and delivery. Access, discrimination, and fear of labeling cause people to delay or avoid care, says the World Health Organization. Delivery mental health care is systemically under resourced, and quality of care can have massive gaps in it. So, what that means is that not everybody has easily accessible care for mental health, and then the quality that you receive can be all over the place. I felt that throughout my time as well when I've gotten out of the military and tried to seek out different counselors, different therapies, different therapists, and the quality of care is massively gapped. And if you go outside of a major health company, you can have massive gaps with it. And then work in school, discrimination in the workplace or at school can have major impacts on symptoms and undermines people wanting to receive care. As you can see in this diagram, you have 7 different people, and one person is checked off, and the rest aren't. And so there's a lot of undermining for what people want to receive in treatment. Impact on healthcare quality, workforce factors, provider bias, and limited culturally coordinated care lower the engagement. So culturally coordinated is that whatever your culture is, where you're from, and what you believe in, and what you want to receive. I can talk about, one of the therapists that I went and saw. I'm allergic to cats. She has cats all over her place. I walked in there. She told me to take off my hat that I know better being prior military, not to wear hats indoors. And then this cat, the whole time that I was talking to her through this appointment, was using me as a scratching post. And so, when we're talking about culturally coordinated, is that even in that minimal area of just having a cat in the area and it crawling all over me and all these different things, I immediately no longer wanted to see that. And so the outcomes are higher symptom severity because you're not getting the treatment. Some people are having to use the emergency department to get mental health care, and you're not going to get what you need there. Dropouts from therapy, like I spoke about. You go into a place, you don't receive the culturally diverse care that you're wanting, and they drop out. And then unemployment or demotion from work. A lot of people have to take time off of work to go get this care. So they could lose their jobs, they could be demoted from their job. There's all sorts of different ways that this has an impact on the quality of the healthcare that you're receiving. Financial costs is another huge part of it. Out of network costs can skyrocket. Out of pocket costs when there's limited providers. Job loss, like I spoke about earlier, people having to take time off and to go see mental health providers, and they're missing time at work. And there's that stigma again that you don't want to tell your profession what you're doing and where you're going and who you're seeing because of that stigma of being worried what they're going to think. Even with insurance, you have copay and out-of-pocket deductibles can rise the cost. There was this fact that from 2018 to 2021, for polled people on average spent 10% of their family disposable income on out-of-pocket mental health expenses a year. So people are spending 10% of their disposable income on healthcare because of the reaches that they don't have. Regulatory and policy. The parity law dictated that mental health benefits cannot be more restrictive than conventional medicine. So what that's saying is that for you to go see a primary health physician needs to be as easy to see a mental health professional, and that the cost cannot have this major disparity either. Rules of enforcement, as we've seen over the past 10-15 years, that mental health is something that's being sought after and being talked about, and federal updates are ongoing to close the gaps and recover comparative treatment. Not allowing loopholes to limit treatment, not allowing jargon to slow it down or insurances to deny the care. And then 988 Suicide Crisis Hotline, Lifeline. This is something that I learned about just recently. I didn't know that in 2005 it was created. It was not talked about. It's used as the 911 for suicide and crisis. And it's been updated throughout the years that you can text it, you can message it online, you can get the help and ensure timely response with care. That came from the FCC. And then evidence-based solutions. Contact-based anti-stigma programs outperform awareness-only approaches. So having it contact-based and anti-stigma rather than, hey, we need to be aware or mental health awareness or this or that, it's the stigma programs being out there. Integrating primary care and school support improves access. So integrating your primary care with your mental health professionals, and then having school support and people that you can go talk to, and school counselors, and some schools have therapists on campus. Fortunately, my son's able to go to a private school, and they have that on campus that they can go talk to a mental health professional at their school. And then workplace policies with reasonable accommodations and anti-discrimination training support recovery. So reasonable accommodations, like allowing people to go get the treatment that they need, being able to miss an extra 30 minutes after their lunch break or prior to their lunch break, being able to go see this. And then anti-discrimination training support recovery. So anti-discrimination training is specific in the fact that we are talking about sitting down, getting training on what are the things that are being said that you may not understand you're discriminating against somebody, but it's just like, sexual harassment training or anything like that, that anti-stigma, anti-discrimination towards mental health needs to be integrated for training in your workplace as well. And then us as professional nursing advocacy, what can we do? We need to advocate for our patients, screen and refer early. Now every single time that you go into a medical office, you're being asked, do you feel safe at home? Do you have any suicidal thoughts? These are all screening tools to find out early and being able to refer them. Coordinate care. We talk about coordinating care all the time, and it can't just stop at going to see an orthopedic surgeon or going to see physical therapy or going and see somebody for diabetes. It has to be coordinating mental health care as well, being able to make sure that they're getting the care that they need to receive. Advocate for policy reform, not just out in the United States, but within where you work as well. Even for nurses as ourselves, we have to understand that mental health is a huge part of it, and we need to advocate for policy reform within our places to be able to go see the treatment that we need. Reduce structural barriers. So we're talking, can we do online therapy? Can we do telehealth? Can we do this? What are some of the structural barriers that people have that we can change that for them? And then education on anti-stigma. So educate them that what they're feeling or what they're seeing, and that mental health is no longer something that should be looked down upon anymore. Yes, that was the past, but that is not what's truly going on now. So we need to educate them that the stigma is changing around mental health. And then culturally responsive care. It's something that's missed heavily within a lot of areas, but culturally responsive care when it comes to mental health, making sure that they are going to go see somebody that they're comfortable with, not feeling like they are going to go see somebody and sit there and feel like they're being judged the whole time. And maybe, if they're religious, getting them to see a chaplain that's trained in mental health. When I was growing up, the church that I went to had a licensed therapist that was a pastor there. And so maybe those are people that we can get them out to see. So making sure that it's culturally relevant to who they are as a person and what works for them. And then the last page that we have is the references that I used for this PowerPoint. The biggest thing is that we need to get rid of discrimination and stigma and help people get to the care that they need to see. This is no longer something that is hidden. It's not in the shadows. It's not something that's looked down upon. And yes, there's generations that still feel that way, but it's something that we need to change and we need to push forward for. And we need to continue to advocate for mental health.